Again, thank you so much for giving me the opportunity to present this work. This work is actually it is in initial phase. So um, as I mentioned, it is augmenting resource allocation techniques for management of ICU beds during the COVID-19 pandemic. Um, Richard Nichol, and Richard George, who are head of data scientists and also chief data scientist in Faethm AI company, were involved in this work. So first of all, what is the Faethm AI company? So Faethm actually is um, growing a startup that works on future of works, and also we are trying to capture the impact of technology on the future of works, and also helping people, industries, companies, and governments to plan for their reskilling, upskilling, and long-term plans for their their workers. Um, so there are different products in Fathom AI. For instance, analyzing the future skills, analyzing future jobs, and also different changes that may happen for the jobs and the skills. So newly discovered coronavirus, or COVID-19, um, actually is a disease that, um, first of all, WHO learned about that in December, 31st of December 2019, and the first cluster was reported in Wuhan, China. After a while, we face a dramatic increase in number of infected people. As you can see, this data is from Wikipedia, so it's the number of cases actually increased during the past almost 12 months, and currently we have more than 70 million cases uh, worldwide. So the research problem that we focus on is actually during this pandemic, many countries face ICU bed shortages. So this was one of the main challenges of health workers and health systems around the world. Um, so they followed predefined strategies. So there are some predefined strategies around the world for health systems to how to deal with ICU bed shortages, not only in the during the pandemics, during the wars, during any on-demand situation. So in this situation, health workers and physicians actually should um, choose not to save some of the patients and focus on actually saving some others. So, as you can guess, this decision is really challenging for those people who sought to treat any people and any person without considering the gender, their religious beliefs, their nationality, and so on. So this is really challenging for these kind of physicians and health workers around the world. So this decision can ethically and emotionally actually put them in a challenging situation. And you should know that definitely that the environment that they're working on during the, for instance, COVID-19 is already a stressful environment as well. So our goals is actually to propose an automatic approach to manage ICU beds in hospitals. to first of all provide a fair ICU resource allocation, and also to relieve the physicians and health workers of having such decisions regarding to whom they should allocate ICU beds and to whom they shouldn't allocate that. So our contribution actually are as follows. So we, to the best of our knowledge, um, this is the first automatic ICU bed allocation algorithm that could be used in pandemic situation. And also we present some key criteria and priority formulas for receiving the ICU beds, and also we um, tested the approach on a sample data set as well. So the research scenario is like that. Um, Imagine at the left-hand side, we have some patients, 5 patients in particular. Uh, at the same time, they go to the hospital, and in this hospital, we have only two ICU beds. In some cases, even we have only one ICU bed in hospitals around the world. Um, and our approach is actually trying to evaluate the priorities of the patients and then allocate the ICU beds to the most to the people with the highest priority, which in this case, in this example, for instance, are the patient 3 and patient number 4. So as you can imagine, we cannot save all of these patients. This is a sad story, and unfortunately, this is the case in a real world scenario. But we should come up with a solution to at least save um, the, the patients with the highest priority. So these are the outlines. We first focus on the patient priority and then CPU scheduling algorithms and then scheduling approach that we have and survival rate. So the patient's priority, how the health systems around the world actually calculate the patient's priority. So as I mentioned, there are some different predefined scenarios for such occasions, and health systems follow those predefined instructions. So one of them is actually saving larger number of patients uh, that they have the more potential years of life. You can interpret this one as saving um, younger people. However, there are different parameters as well. So, for instance, a person could be young, but he or she could have cancer. So, health workers actually assess these kind of parameters. Um, is this patient actually survive uh, and has more potential years of life compared to others or not? So the age of that person is one parameter, but there are some other parameters as well. The second one is in some countries like US, they allocate higher priority to homeless people. It may seem strange, but it's because they cannot actually provide for themselves a self quarantine space, and this can spread the virus. And finally, there is a higher priority for the health workers themselves because they are valuable for health systems around the world. So we actually consider the previous parameters as well as follow the New York State Task Force guidelines on life um, uh, and also the health during the pandemics. Um, they actually propose a score which called sequential oral failure assessment, or SOFA. So during the pandemic, New York and many other states in the US actually follow these instructions and also use this score for scoring the patients and allocating priority to the patients. So this score could be calculated via this table. As you can see, there are different factors in this table: level of oxygens, liver function, low blood pressure, and kidney function, and so on. Um, they have defined some scores for different scenarios for each row. Um, so if a patient actually presents in a hospital, they firstly evaluate his or her conditions based on these scores. And finally, they give a score between 0 and 24. So each row has a score between 0 and 4. And finally, we could have a score between 0 and 24, and the patients with the higher scores could be in a more dramatic situation. So based on those parameters, we came up with a regression-based formula to assess and also define the priority of a patient. So based on this formula, we assessing the priority of patient I at time t, and as you can guess, the situation of a patient could be different during the time, and it could become worse or better. So we should assess this priority during the time. So PLI is the potential years of life. HW is he or she a health worker? So it is 1 or 0. And HL is he or she homeless or not? And so far, which we discuss, we can calculate that based on the previous table. As you can guess, so far and PL are not binary like HW and HL, so we um, normalize them to have a fair impact on this formula. So they could be between 0 and 1. And after that, we allocate some weighting parameters for controlling the impact of um, each factor or each parameter. So after all, we have a priority for patient I at time t. So what is the usage of CPU scheduling algorithms in this research actually? So we came up with this idea that ICU beds are kind of like the CPU resources. So as you be familiar with the, for instance, the CPU scheduling and the operating system scenarios, um, how they how the operating system actually allocates CPU to the applications in computer um, usage that you have. So they have some certain scenarios and instructions to allocate CPU to each application, and CPU are the resources. And in this research, we assume that CPUs are like the ICU beds. So we have some ICU beds, applications are the patients, and we want to come up with a solution to allocate the ICU beds to the patients or CPU to the applications. So there are two kinds of CPU scheduling algorithms, primitive and non-primitive scheduling. So primitives one are those that after allocating CPU to an application, if a higher priority application came up, So we actually take the CPU back and allocate that to the application with a higher priority. Non-primitive is the vice versa. So if you allocate the CPU to an application, you cannot take it back until that task uh, actually be completed. So the scheduling approach that we want to have here, what is that? So according to the New York guidelines for health and life, um, at any point during the time trial, even before an official assessment occurs, if a patient develops a condition on the exclusion criteria list and there is an eligible patient waiting, then the ventilator actually is relocated. So I should mention that in this research, we use the ventilator and ICU beds at the same level and at the same meaning because um, for the pandemics like the COVID-19, you should have the ventilator. Otherwise, that CPU, that ICU bed is useless. So these actually guidelines guide us that if a patient with a higher priority comes in, so we should take the ventilator back and relocate it to the new patient with a higher um, priority. So again, this is a sad story. If you can imagine, we as a health worker and I mean um, physicians, we allocated the ICU beds and ventilator to one patient. One patient with a higher priority came in, and then we should take the ventilator back and allocate it to the new patient. So that is a sad story, but unfortunately, it is a true story. So because of that, we should select the primitive scheduling algorithm and employ those kind of algorithms for managing the ICU beds. And finally, we define a survival rate for assessing um, the performance of our proposed approach as well. So in this scenario, actually, we have HP divided by THP. Um, so HP is the number of high priority patients that were served with an ICU bed within 1 day of their presentations. We assume that if that patient, that high priority patients, um, wouldn't be served by 1 day after his or her presence at the hospital, so it's kind of useless to allocate that ICU bed or the ventilator to him or her after the 1 day. So our assumption is they should be treated within a 1 day. Um, so this is one assumption. It could be changed in different scenarios, but it is reasonable to consider 1 day as a critical, um, I mean, timeline for saving a patient, a high priority patient. And THP is the total number of high priority patients that are presented in the hospital. So after we divide them together and then multiply by 100, we can have the survival rate of the algorithm or the resource allocation algorithm. So because we didn't have access to the real world data, so we came up with a sample data set. We created a data set with 100 patients with different with different um, um, uh, parameters like the age, different uh, um, SOFA scores, and so on. After that, we apply these proposed algorithms on those sample data to actually um, manage their ICU beds. So our assumption was we only have one ICU bed. So this is a very critical situation. So many hospitals around the world actually either they don't have any ICU beds or um, uh, ventilator, or they only have one. So to be similar to the real world situation, be more similar to the real world situation, we actually consider only one ICU bed in this scenario. And we have 100 patients and with different arrival time. So we want to actually allocate this one ICU bed to these 100 patients and try to save as much as we can from high priority patients. So as you can imagine, not all of these 100 patients are high priority patients. So an approach could be good if it can save a higher number of high priority patients. So the waiting time for many of them actually, as you can see, is are zero, and some of them are more than zero. So one way of assessing an algorithm in this occasion is um, if it actually saved the high priority patients first, which in this case um, we actually did the high priority ones. As you can see, the column priority um, shows the priority of these patients. And these 15 patients actually are the most, they have the highest priorities in our sample data. So it succeeded to save those patients, but we also are looking for the waiting time for these patients as well to calculate the survival rate. So to have more experience on this data, we also apply two other algorithms, SJF or shortest job first algorithm, which is another CPU scheduling algorithm, and also first job first serve in on this data as well. So as you can see, the average waiting time or AWT for all patients, although it is lower in shortest job first algorithm, and our algorithm actually has the highest average waiting time for all patients, but we have the highest treated patients among these algorithms. And also, average waiting time for high priority patients in our approach is 17.2, while in the other two actually is 146 and 194, which means that our approach actually mainly focus on the high priority algorithm because we use primitive priority scheduling algorithm, and our approach actually focus on the most the patients with the highest priority. And finally, the survival rate, as I mentioned, the number of the high priority patients compared to the that we actually serve during the one day compared to the total number of priority patients and multiple by 100. So as you can see, the survival rate of our approach is 27%. And other indications that our approach actually focus on the highest priority patients, and also you can see the performance of other algorithms. So we should also at the end mention that this is only a sample scenario, and also if we want to apply to the real world scenarios, it requires the extensive risk management process. and we are at the earliest stage of this line of research, and we strongly advise that people to assess the um, any risk that actually adopting this approach could have in a real world scenario, and then apply it. So in for future work, we definitely plan to come up with a more mature machine learning algorithm using deep learning algorithms, and also, main importantly, focusing on real world data from the health workers around the world. Thank you so much for your patience, and I will be happy to have answer any questions.